All right, good afternoon. We're going to go ahead and get started. We have some members who are going between health services and state government, so I need to go ahead and start since we have a quorum at the moment. I hereby call this meeting of the Health Services Committee to order. We only have a couple of bills for consideration today. I'd just like to welcome, I guess, all of our guests. Are there any members who have any guests that they'd like to introduce? Okay. DJ, please take the roll.
Representative Bratcher, Representative Bray, Representative Burke, Representative Callaway, Representative Camuel,
Here.
Representative Dotson, Representative Fleming, Representative Gordon,
Here.
Representative Holloway,
Here.
Representative Marzian, Representative Neighbors,
Here.
Representative Proctor, Representative Rayburn,
Here.
Representative Raymer, Representative Riley, Representative Sharp,
Present.
Representative Wilner,
Here.
Vice Chair Duvall,
Here.
Chair Mosier.
I am here. Okay, we have a quorum and quorum established and can proceed with business today. I think at this point I will go ahead and call House Bill 389, Representative Duvall, to the table. If you have any guests, have them join you, and everyone introduce yourselves for the record and proceed with your testimony.
Representative Robert Duvall, District 17, Warren County.
Josh Hardesty, Executive Director of the Office of Legislative and Regulatory Affairs for the Cabinet for Health and Family Services.
Tim Anderson, Assistant Director, Office of Inspector General.
All right. Chair Moser, members of the committee, thank you for the opportunity to present today. House Bill 389 is a cleanup bill that simply addresses problematic issues that the Office of the Inspector General has encountered as it has implemented the CASPR program. CASPR is the Kentucky All-Schedule Prescription Electronic Reporting System, and these changes cannot be accomplished through regulation. Similar language was included in House Bill 290, which passed the House 98-0 in 2023. There is only one difference between 2023's bill and this year's proposal. It addresses the definition of practitioner in Section 2. The change simply aligns the definition of practitioner so that it is the same for both out-of-state and in-state providers.
We have a motion and a second on the bill. Is there anything else that you'd like to add? Okay. Are there any questions from any of our members? All right, we'll see none. DJ, please take the roll.
Representative Bratcher, Representative Bray, Representative Burke, Representative Callaway,
Aye.
Representative Camuel,
Yes.
Representative Dotson, Representative Duvall,
Yes.
Representative Fleming, Representative Gordon,
Yes.
Representative Holloway,
Yes.
Representative Marzian,
Can I briefly explain my vote?
Yes, of course.
Thank you. I enthusiastically vote yes. And I think this actually gives more access to our patients that need it so desperately in the state. But thank you all for this bill. Thank you, Madam Chair, for a co-sponsor. Thank you.
Representative Neighbors,
Yes.
Representative Proctor, Representative Rayburn,
Yes.
Representative Raymer, Representative Riley, Representative Sharp,
Aye.
Representative Wilner,
Yes.
Chair Mosier.
Yes. Okay. House Bill 389 passes unanimously, and the same should pass on the House. Congratulations, and thanks for your work.
Thank you very much.
Of course. Okay, next we will hear House Bill 501. I believe we have Representative Whitaker and Representative Derek Lewis. So introduce yourselves for the record and proceed with your testimony.
Thank you, Madam Chair and committee members. House Bill 501 provides continuity. Oh, I'm sorry.
Introduce yourself.
Oh, yeah. I'm Mitch Whitaker, State Representative of the 94th District.
Thank you.
Thank you, Madam Chair, members of the committee. Derek Lewis, State Rep, 90th District.
House Bill 501 provides continuity of care when a patient's healthcare provider dies by allowing the prescription to be filled for a determined period after the death. Currently, there's no law in Kentucky about whether a pharmacist can fill such a prescription or cannot fill such a prescription, leaving uncertainty and potential legal liability for the pharmacist. Importantly, controlled substances are excluded from this bill in compliance with federal law, and the pharmacist will still be able to exercise their professional judgment in whether they fill the prescription or not. If my co-sponsor would like to speak, I'll turn it over to him. Otherwise, I'll answer any questions and ask for your yes vote.
Motion on the bill.
I don't have to speak.
Okay, all right, thank you. We do have a motion and a second on the bill, and Representative Camuel, you have a question.
Yes, thank you, Madam Chair. I'm just wondering if there's any type of specific documentation or verification that'll be required to verify a deceased practitioner's prescription.
Thank you for your question, Representative. So I actually sadly had this come up. I have some pharmacies in eastern Kentucky, and sadly I had a nurse practitioner pass away in a road accident. And so that happened, I believe it was on a Friday. I came in on Monday, and I was thinking, I've never had to deal with this before. Are prescriptions still good? I mean, typically how we've always been told, I mean, again, I haven't encountered it, was the DEA had regulations on file for scheduled drugs that you essentially would not fill those, but on refills, Board of Pharmacy would always say use your professional judgment, and that's where you start getting into questions of liability. So I called the Board of Pharmacy, and I was like, how are we supposed to treat this? And they were like, well, really, we don't have anything on the books. And so the language that Representative Whitaker's put together, and I appreciate his leadership on this issue. I was telling him about it. He's like, well, let's file a bill. But we've been working alongside the Board of Pharmacy, and then also making sure we didn't overstep into DEA. But in terms of documentation, on my stores, I would typically probably make that notation on the script, on the hard copy of the script, and scan that into the system.
And something I'd just like to clarify is this is only when the pharmacist knows of the provider's death. There's no mandate in this bill to go out and verify that the provider's still living. This is just if they are aware of it. They have these guidelines to go by.
That's perfect. Thank you so much.
Representative Sharp?
Thank you, Madam Chair. Has KPHA weighed in on this?
They have. They're good with it. There's a few changes that we'd like to make for simplicity, which I'm happy to discuss with them. We didn't have it ready in time for anything for you all to consider today. But yes, they're supportive. And I actually had some folks from the retail pharmacy or specialty Pharmacy Association come in, and they didn't know about the bill, but each one of those pharmacists had a situation like this where someone had wrote a prescription one day, died the next. So I think everyone's on board with this. I haven't heard any opposition.
Okay, thank you.
Okay. See no further questions. We have a motion and a second on the bill. DJ, please take the roll.
Representative Bratcher. Representative Bray, Representative Burke, Representative Callaway,
Aye.
Representative Camuel,
Yes.
Representative Dotson,
I'm a yes, but I'd like to record my attendance and a yes vote for House Bill 389.
We'll have to do that after we finish this roll call,
Sure.
please.
Yes.
Representative Duval,
Yes.
Representative Fleming, Representative Gordon, Representative Holloway,
Yes.
Representative Marzian, Representative Neighbors,
Yes.
Representative Proctor, Representative Rayburn,
Yes.
Representative Raymer, Representative Riley, Representative Sharp,
Aye.
Representative Wilner,
Yes.
Chair Mosier.
Yes. House Bill 501 passes with favorable expression, actually unanimously, and the same should pass on the House. Congratulations, and thanks for this good work.
Thank you, Madam Chair.
You're welcome.
Thank you, Madam Chair, members of the committee.
Of course. Okay. Next, we are going to hear House Bill 414. And I don't know, is Representative Tate going to be here? Or you're welcome to join us at the table and explain this if you would like, Adia. No? I don't know where. Oh, she is. Okay. Okay. Well, we can go ahead and ask for any members who need to record their presence or record votes.
I'd like to record my presence and a yes vote for House Bill 389. Thank you.
Okay, thank you. Do we have anyone else who had to step out? Okay. All right, thank you. Oh, good. Yes, Representative Tate. All right. Thank you so much for being here. We are hearing House Bill 414 for discussion only today, and I'd like to welcome our presenters. Please introduce yourselves for the record and proceed with your testimony.
Thank you, Madam Chair and members of the committee. I'm State Representative Nancy Tate, and I represent District 27, which is Meade and Hardin counties.
Thank you, Madam Chair and members of the committee. I'm Adia Wushner, Executive Director for Kentucky Right to Life and RN and OB nurse. Thank you.
So House Bill 414, we heard this last year, but we felt like that it was important to talk about this topic again because it's not something that's going to go away. It's actually known as Love Them Both, and it's the whole point is to provide support to women and their families in situations where they might have a pregnancy where it isn't going to turn out exactly perfect. And so we feel like that it's very important. It's very similar to hospice care, which is for, adults, but this is perinatal palliative care, and that's care when for financial, spiritual, emotional support for the families. So I asked Adia Wushner to come in and sit with me for this because she and her experience as a nurse has had a lot of experience with situations similar to this.
Thank you. Thank you, Representative Tate. I think I'll begin from a clinical perspective, and even as I spoke to Dr. Goldberg, who is over Kentucky ACOG, and ACOG nationally has supported this legislation or this movement, and they support perinatal palliative care so that you understand it is a multidisciplinary approach to women. So a little bit different than hospice because normally in hospice you have one patient. Everyone of this multidisciplinary team knows that they have two patients. They have the expectant mother and they have the fetus or the unborn child. And so often there are medical complications, there could be anomalies that are occurring, and they also have the family. So in that approach from OB to perinatal to our maternal health to even clergy and nursing, everyone is prepared to approach this in that broad level of care. Now on the menu of services when this occurs, there are many things. The first thing, sometimes when you have especially a genetic anomaly that occurs or a complication, is that the family and the mother are first why. So if they should want genetic testing, that's one of the services that are offered. They don't have. There's nothing on a menu in that complement of care that you would have to take or you're forced to take. But what we're asking in this piece of legislation is that birthing centers, physicians, OBs, those that care for women who are going to have children, when they have a complication occur or a diagnosis, that if they don't have the program in their healthcare facility that they or birthing center, that they would refer that patient to that program. And because it's very important to, in a sense, we all want the best outcomes for women. And so to wrap those services around them and let them pick and choose off the menu of services. What's very beautiful in some of the programs that I've worked with, not only is it the ministerial approach, but to walk with them, maybe introduce them to other families that have also had similar experiences depending on the diagnosis. Recent survey that was done 2 years ago of about, I'm going to say maybe I think 240 patients. They weren't here in Kentucky, but those that entered into a program, Some of those children died before delivery. Those pregnancies ended before delivery, and they walked with that family during the grieving process. Some of them lived just moments after delivery, and they allow that bereavement time with that family is also planned in, which is very important. Should they choose it? Should they choose? And the other, about 41% of those children continue to live. And so connecting those families to supportive services they may need depending on that child's outcome and needs, and what the mother may need. So I've kind of given a broad brush, but again, this is very pro-woman, and I hope that you all will be able to eventually consider this piece of legislation.
Yeah, thank you. I really appreciate your work on all of this. And as a former neonatal intensive care nurse, I saw a lot of these babies and these families, and I saw them go through this grief period and really not have the support that they needed. And so I feel like this is an important option for families, and I just really appreciate all that this support system is offering to families and the work that you've done on this. So, do we have any questions from any of our members? Representative Camuel.
Thank you, Madam Chair. Thank you all for coming to the table, and I appreciate you all having this for discussion only today, because as we know, it is a very personal and important conversation to have, and it's difficult for anyone who has experienced a miscarriage or had a situation where there was a fatal fetal anomaly and the anguish that an expectant mother goes through. One of the questions that I have is how many perinatal diagnostic centers are there in Kentucky that can diagnose, like really do the diagnosis of a fatal fetal anomaly?
As far as diagnosis, there are multiple hospitals, some of them that offer these services. One of them, broad range, would be, let's say, Footprints Program, which is at St. Elizabeth in Northern Kentucky. Every hospital, your teaching hospitals, they offer those diagnostic services and refer to it. And hopefully what we don't want to have happen is, and I hear from a woman who's in a different region of the state, and she said, I didn't know. No one referred me to find out why this happened. One of the things we want to make sure is that if there's a fetal anomaly and trisomy or a diagnosis, that what happens later is that she's tested so she knows why and why this happened, and especially if it's something could be preventative or if it's something that could be congenital or from both sides. So, but as far as who offers all the services, do you have a number? I don't have quite a number, but we know our universities, hospitals, Norton's, different ones in the state, but it's not offered throughout the entire state.
Okay, thank you. May I ask just a follow-up on that? Mm-hmm. Oh, thank you. And I appreciate that, because part of my question, what I'm wondering is, of these hospitals or diagnostic centers that can diagnose a fatal fetal anomaly, do any of them not already offer palliative care services?
Well,
it's my understanding that they all do, that they all offer services.
They
to
some
women.
do, but what happens is sometimes women are not referred, and that's why even when speaking with Dr. Goldberg, we just want to make sure that all women, if they're aware of these, that the providing physicians would refer to a center or to a service. Some of them do not offer the complement of pastoral services, and so to have sort of a collective view of all the services could be offered. It's not just diagnosing. It's not just making a diagnosis of and hooking someone up so that they can have all the genetic testing. That's only a small part of it. Much of it is the process that women go through in the families, the grieving process, the fear, having an opportunity to speak with other families that have experienced the tender care that goes along with this complement of the entire program. And they don't all offer that program. Or someone who was actually a patient at one of our hospitals in Lexington sadly didn't know the whole full spectrum of services that could have been offered to her, and her heart was broken. Because as she said to me, if I'd have just had something, held my child for a moment, a lock of hair, perhaps a photograph, some of the things that can be wrapped into this tender program that includes bereavement, that was not offered to her. So I'm just sharing that from experience.
Right, and I definitely understand. And I'm sorry, may I have one more? Just to
yeah.
tie the knot on this one. And what I want to say is, again, I appreciate you all bringing this, and if there are hospitals that are not offering the services or not making the referrals, I hope that that's something that we'll be able to talk with the medical societies about, like the associations, to make sure that we're offering the full complement of care. But also, I'll stress from my personal experiences, and happy to share those with you all if you ever want to talk about it. I think it's really important that we make sure that any type of medical decision, mental, physical, emotional, that we are leaving this up to the doctors who are trained to provide the care. So I don't want to force anybody into making a decision or going through something that they actually did not want to do.
And
so I appreciate that. Thank you all.
Thank you, and I appreciate that, and that's why we've both stressed that it's optional. You know, it's something, a service that is offered to the patient and their families. And as you've stressed, we've all had situations. I'm sure that, you know, both the men and the women sitting in the seats up here, we've all had those situations. And I know from my personal perspective, I had 3 miscarriages before I was referred to a high-risk doctor. So there were those were very traumatizing situations for my family and I, that we were not offered these services. And I think that it would be very crucial and important for the emotional support for that family. So I appreciate that. Thank you.
Thank you. Representative Fleming.
Thank you, Madam Chair. I just wanted to touch base with you, and I appreciate our conversation earlier, but I just want to ask this on a publicly. I know the intent is to provide as much support for women who are going through this event and horrible situation that they got to deal with. In your language, you have counseling on there. I know your intent, but as a suggestion, as this comes to fruition, and it could be hopefully put forth into the General Assembly, I'd like to have that modified to include that this includes like licensed mental health therapists that will provide the counseling, just for clarity, because counseling can go any different ways in order to do that. So I just wanted to just provide that suggestion to you in order to do that.
Yeah, so Representative Fleming, I truly appreciate that, and I did ask you to bring this up in the committee, and I appreciate that, and I would be willing, Dia and I would both be willing to have that further conversation. And as a counselor, you understand the importance of the definition of that terminology. Part of the counseling, too, that would be offered would be spiritual counseling as well, financial counseling. So there's a lot of different services that could be offered, but I appreciate your interest in making sure that there's further definition.
And I appreciate thank you. I'm not a counselor.
Oh, sorry, I thought you were.
No, I run a mental health center, but
Gotcha.
I'm not a counselor.
Gotcha.
That's way above me in order to provide that type of service. But I appreciate that. But yeah, that'd be good if we can talk further. And it'd probably be a really simple change in doing that. I do have another question, Madam Chair. Thank you. These services that's laid out here, I guess, how will this be enforced? I know you have a website to provide all these services and resources, but it was stated that some of these, like you yourself just mentioned, that you didn't have, weren't offered that. So how is that going to be enforced? How is that going to be monitored?
I would say this isn't something about enforcement. You know what I'm saying? This isn't like a law, breaking a law. This is asking our healthcare providers to provide the service and to ask the cabinet to keep a list of those, provide a list, keep those list of services across the state. So it's not like a traffic law that we create or enforcement or there's punishment for not providing them. We're just coming forward saying this is what we want, would like to see and assure for women across the Commonwealth, on families across the Commonwealth, so that their referrals can be made. We don't have enough. If we have more birthing centers, we need the complement of services for women, because too often you hear that I wasn't referred, I didn't know. And remember, this doesn't take away their choice, even if they choose to go out of state and I'll be honest, to terminate their pregnancy. That's still a choice that a woman may have. But so often they didn't know when they heard someone else, especially about, she was able to hold her child with anencephaly, who only lived for moments, even though it was tenderly wrapped with this is a child that doesn't have brain development. But and they have a little skull cap, and to be able just to hold that child for, I often say as I used to do grief counseling, of course, in our birthing centers, that sometimes you can't say goodbye until you said hello. And it's just those tender moments. And sometimes it's just, for some moms, just to be able to touch a foot, see a part, maybe not see it, but just to hold that child. And the one mother who came forward, and I think it might be, and I'll check back, in your district, I believe, in your district, that came forward and said, I never had that opportunity. So tenderly wanting that opportunity for the counseling, we can talk about that and share that, because sometimes the grief continues on, and I do think referral for counseling for people who have long sustained grief is important as well. But if you'd like to see kind of a program that's up, and it's called Footprints at St. Elizabeth Hospital in Northern Kentucky, but to see their complement of services and how they're laid out, I think they do a very good job to kind of give you a better guideline on that.
And I appreciate that explanation. I wasn't intending for us to be any type of penalty or anything like that.
Okay. Good.
But my intent is that, we even though I was a Metro Council, we pass a lot of things, and it's not adhered to. The administration doesn't enforce it, and so we can do all we can. But when the rubber hits the road, it's not there. So I just want to make sure that there is enough, promotion, marketing, and making sure that these individuals are aware of these particular programs, and so that. One last question, and this is more of a curiosity question. Under our current the abortion law, will these services be applied to those individuals that will be in a life-threatening situation and have to go through whatever they need to go through? Will these type of services be offered to them as well, or be made available?
Most certainly. I mean, imagine, you're facing a life. Now, a lot of times it can't happen at that moment, but bereavement is so important, especially for women who the family has planned a pregnancy and things do not go as they expected. That's a full complement of services that we want for all women and families in the state, no matter what the conditions that apply. So most certainly, sir.
Okay, but the bill is basically for around birth time.
Right.
That's what the bill's for.
We think of birth, and what we kind of call that as a delivery plan. And for her, for women who face a life situation, and then that decision has been made that because of her medical condition, now we have a pregnant woman that now needs to be, sadly, every attempt is to save both under the guidance, and that's how medicine practices. No one comes in and says, I'm going to terminate this pregnancy, and we're not going to make an attempt to save both the mother and the child. That is clinical standard practice across the board. But sometimes it's either too early in fetal development, or the complications are so severe that you can't save both. When that delivery takes place, and I always want to say this, in that delivery room at that moment, it's not just the OB-GYN, it is a neonatologist, it is a neonatal team. Everyone is on board in an attempt to save both. And so, but having those wraparound services, sometimes it may be so immediately they're not there for her at that moment, but they come later. I will just share, I got a call last weekend from a grandfather, and who said, my son is just had a miscarriage, and they are at the hospital in Louisville. And he was first upset because didn't understand the law. So I'm going to thank you, because his grandfather and this family were very thankful later because of the legislation you passed. I wanted to share that. You all passed that when they realized that they didn't understand why there was a birth certificate, but they later realized that the remains of their child will be placed in Calvary Cemetery in Louisville, in the Holy Innocents area, because of the legislation passed by this body for the dignified care of the remains of a child. So I wanted to add that. And so again, that complement of services, if the family chose that even after the loss of a child, we want that to be there for them if they need it. Does that kind of tell how broad it could be?
Yes, I appreciate it. I just want to clarify that the totality of care for the woman is there, and making sure that they provide as much support as possible. I don't know if you're referring to the same person I'm thinking, but I got a call from an individual from my district that just had a very bad situation, and they did not feel comfortable with a lot of the documentations they had to sign in order to go through that process. But I asked them if what type of support do they have, and they're comfortable in what they do in their life, and so they have the availability. But there are others who might not have that ability. So that's what I was trying to get to. Make sure there's a wraparound service support. So thank you very much. I appreciate it.
And the language that we passed made it optional where they would get a birth certificate, because there were several individuals that were requesting that was not available to them.
Yeah, thank you. Thank you, Representative.
Right. Okay, thank you. And I would agree. I mean, this is an important discussion. This is really about an enhancement of services that we can provide to those families. And I would even like to see this take place in a neonatal intensive care unit where you have a critically ill infant, and those families need a lot of support.
Absolutely.
So I think this could.
That's correct.
I wanted to add, sometimes, and I know maybe you probably have never seen this, but sometimes those children do not live long even when they go home. And when they're brought into the emergency room, what happens even there is they set aside, as you know, a tender place, a place where that family can come and grieve and have even those moments during that time of loss, and where even the grandparents, and sometimes they will hold that room set aside for that family in the centers that have these programs for 4 and 5 hours, just to allow them that process. And so just as we have so much joy when life comes into this world, we need that time often as life leaves this world.
Right.
Thank you.
And just to tag on one other thing, to something that Representative Fleming said, just recently I was in I'm the guardian for my 91-year-old aunt, and so she was critically ill in one of the hospitals, and there was a nurse that came by that was a geriatric emotional support nurse, and so she made herself present, and I said, I hope I don't need you, and she said, Nancy, I'm here in case you do. And so that was just so much comfort for her to stop by the room and to say, we're here for you if and when you need us.
Thank you. Representative Callaway?
Thank you. Thank you all for working so hard on this bill, for focusing on moms. We've recently, in the last couple of sessions, been laser focused on moms, showing the love, and I just really appreciate that. They need that. The bereavement process that we're talking about, it affects moms, and we have a tendency to specifically, supremely, thoroughly, with partiality, elevate the moms during these pregnancies and these bereavement processes. And we have a tendency to overlook, neglect, and completely disregard the fathers a lot of the times during pregnancies. So I want to point out specifically that you've included birth fathers, and thank you for that. I think they deserve as much attention a lot of the time as the mom. They don't understand sometimes as much as the mom does. We're emotionally attached to the child. There's things that we progressively, intuitively understand about the processes that the father typically doesn't have. So bringing him in, acknowledging that he is a participant in this, that he is a father, I think it's very, very important in all legislation going forward. And I would like to ask about Section 2 for somebody who doesn't specifically understand healthcare plans and whatnot. It's just elaborate, and we're defining some sections and all this. 2 and 3 specifically, what is all this necessary? What are we doing there?
It's basically from a coverage perspective.
Okay. Are you talking about the healthcare coverage section?
Yeah, just to make sure that we're talking about the same
Section
thing.
2, a new section of subtitle 17A of KRS chapters 304 is created, and then it's got except, notwithstanding KRS, and if a qualified health plan.
Let's just talk about it though. Yeah,
That was actually more expanded language, I guess, because as it was explained to us because we kind of questioned, like, where did that come from into the bill? But it's more expanded language when you talk about health care coverage. And so it was a language that was sort of required, that needed to be placed in. We're looking at the drafter, that needed to be placed in the bill. As the legislative body changes things, sometimes the language has to be changed accordingly, so that it's just the covering, that these services be covered. Often they are, sometimes they're blended in, but to make sure that they were covered in the plans. And if you look at your mandates and your healthcare mandates that came back, we're talking about 0.22% on a healthcare plan to cover that per member and a less than 0.05% impact.
Mm-hmm.
But that's language. That's all I can say.
And Representative Callaway, one of the things that we want to make sure too is that this type of service is available to everyone regardless of what their economical opportunities are. And so we don't want to just make it available for someone who is more financially gifted than other people. Yeah. But I appreciate your point too earlier about bringing the father in. Like in my situations, I know that my husband is the provider. He's the protector of the family. And so in a situation like this, he felt like that he was completely hopeless and helpless because he could do nothing to help me from a health perspective. And so I do think that those emotional support is very important for the entire family. So thank you.
And I might add, we've come a long way. It used to be that at the time the mom left the hospital, when a baby was lost or something happened, it was sort of like, go home now. And the husband even sometimes just was left taking care of those arrangements. We've come a long way from that to where we are today. But because sometimes the father is not active with the mother anymore, and so these plans look like they're for moms, there's also set aside, and people that provide these services do have a side service for the birth father, even though he's not actively engaged in a relationship with the mother, because sometimes they're angry, they don't understand grief and loss, and they have no other place to place their loss but through that first part of grieving, which is anger. So there's programs that are there for them as well. So thank you for bringing that up. Thank you.
Okay, thank you. Representative Wilner.
Thank you, Madam Chair. Since you opened the discussion talking about a comparison to hospice, I just wanted to offer a gentle correction. You said that hospice has one patient, and this would have two. As someone who has worked very closely with hospice in my own family, their whole philosophy is centering the family, centering the community around that patient. And so I just wanted to make that clarification. And thinking of hospice, thinking about my own experiences with my deeply loved family members, it is such a personal decision. Mm-hmm. And for me, hospice meant the world. For my mother, hospice meant the world. Mm-hmm. Many families don't want that, do not want that. To them, hospice signals something that is very much in contrast to their own beliefs, their own feelings, their own needs at the moment. And as I hear some of these descriptions, I feel like we might be dipping a little bit into making assumptions about what a person facing a pregnancy with a fatal fetal anomaly might want or need. Obviously, these services should be available. Obviously, families need support. But I think we need to be very, very careful about suggesting that any of us know what's best for any particular grieving person in these kinds of moments. So that's all I wanted to add. Thank you.
Yeah. And I can appreciate that. I have an aunt who does not like hospice. And so from her perspective, they're the ones that killed her husband. And, we know that that's not the case, but from her perspective, that's how it ended up being. And so that's why it's optional and made available. So thank you very much.
Okay, thank you. And Representative Marzion, you've got a question?
Thank you, Madam Chair. Just a comment. Thank you all. Good to see you, Adia. I just want to remind the Kentuckians and Kentucky voters that they soundly defeated Amendment 2 that dealt with abortion, because they see this as a personal, private medical decision, that they do not want a legislative body that often know nothing about health care intruding upon their personal, private medical decisions. I had to laugh yesterday when we had a debate on fluoride on the water, and the sponsor of the-
Marzion, can you just stick to the
I'll wind
subject,
it up.
please?
But the
Thank
sponsor of the bill said fluoride should be a personal, private decision between the provider and the patient. And I agree, medical decisions should be a personal, private decision. And the voters also said the same thing. Thank you.
And that's exactly what this does. So I appreciate your comments, and this is an optional support service. So yeah, okay, thank you. All right. Well, I really appreciate your being here today. Hopefully, we can take this up officially, and we'll see what kind of time we have as things kind of wrap up here this session, but I really appreciate all of your work.
Thank you very much, and I appreciate the opportunity to keep this conversation alive.
Thank you.
Thanks. Thank you, Madam Chair, a member of the committee.
I'm sorry, we are finished with the business today and officially